I'll add you
Good
up, so don't
morning.
worry.
We're starting. Good morning, good morning, good morning. All right, I think we're just starting to let people in. So a very warm welcome to one and all. It's great to have you here as always. For those that are new, because we've got a deluge of new people on the call today, and of course our trusted favourites that turn up every time, could you just pop a 1 in the chat to let me know that all of the sound and everything is working as it should? That is protocol around here. Who's going to be first in? First off the trigger. Lovely. Thanks ever so much. Really helpful. That's my most nervous moment on every one of these calls. Oh, good. Thank you very much, Russ, Sarah, etc., etc. Right, blimey. It's been a whole month, would you believe, since Exon Health announced their strategic partnership with Tortoise AI to deliver Surgery Intellect, a sophisticated clinical AI assistant available to all GP practices across the UK, regardless of their existing telephony provider. Since then, I think it's fair to say ambient voice transcription has become, shall we say, one of the hottest topics in town. Nothing to do with us, we promise. Is that fair? All good. Thank you. Thank you. Keep coming in. Right. We've had all sorts of conflicting information, though, haven't we? From the top down, the bottom up. I'm hoping that today we're going to cut through some of that noise. We've got some fantastic guests that are going to help us with that. To kick us off, though, another 1 in the chat, please. If you have seen or read the priority notification letter sent by the NHS on the 9th of June, you know the one. The ensuring safe and assured adoption of AI technology. Is everyone familiar with it? I mean, if you're not, it really bums out the next question. So I'm hoping so. There's got to be more than that. Got to be more than Paul and Anne. I'm going to assume there is. And okay, well, that's interesting, Andrew. We'll bear that in mind. Anybody else? There's got to be more than that. Anyway, all right, my next question, the follow-up icebreaker is, what is your biggest concern about using AVT in a clinical setting? I'll give you a few minutes for this one because this involves actual typing. But yes, for those just joining, I'm keen to understand what your biggest concern about using AVT in a clinical setting looks like. Are you joining in, Keith?
Oh, sorry, I'm responding to questions. I'm always. I'll keep my hands off the keyboard.
Yeah, hands where I can see them, Keith. Yeah. Data breaches, that's a good one. Keeping data safe seems to be a consistent theme. Okay, we'll keep those coming in. Have a think about it whilst I continue to blabber on. I'm keen to know, for those that are just joining, what's your biggest concern about using AVT in a clinical setting? Yes, Sarah, I do have the link. I'll send it out after this call. Awesome. Right. As I said, we've got some great people on the call today, the right people to help you with those concerns. We've got what I would call an A-list group today. Yes, Dom. Yes, Keith. Yes, after I'm looking at you. But before we get going, I do just want to do a little bit of housekeeping. Firstly, to say the call is going to be recorded for prosperity and sharing. So you're not going to miss a thing if you have to drop off. We know that you're all very busy people. We're aiming to keep you for no more than 45 minutes, although I have been known to be wrong on this before. Second of all, we love the questions, so keep them coming in the chat, in the Q&A. I will be keeping an eye on those. We're expecting a lot from you today, so please feel free to drop them in when you can. We have allowed a little time at the end of the call to cover them off, so don't be afraid to ask whatever is on your mind, especially around those concerns. My name's Lucy Glynn. I'm the Community Manager here at Exon Health. I'm delighted to welcome, for the first time, ahead of his debut at the NHS Strategy Summit tomorrow. It's a mouthful, isn't it, Dom? Dr. Dom Pimenta and Hafsa Amidi from Tortoise AI. Really great to have you both here. How are you doing?
Hello. Doing great. So you revoked my medical license. Thanks for that.
Yeah.
You got promoted to being a surgeon.
It's a good start.
Or maybe promoted. That's an at-home debate with my wife. She's a surgeon. She'll like that one.
Oh, okay. Well, we'll clip that clip just for her. Right. All right. Now, Dom, the big one for me. As fast as we can, as slow as you need. As fast as we can, as slow as you need. It seems to be a really good mantra. It's the philosophy at Tortoise AI. It seems to be particularly pertinent to this contentious area. So unpack it for me. What does it mean?
Yeah, for sure. So, and hello, everyone. I'm very much welcome and thank you for having us. As fast as we can, as slow as we need. So we called ourselves Tortoise for a reason. And when we first started, lots of doctors in the space had looked at lots of the health tech out there, which came to healthcare with the technology mantra of move fast and break things. And we were like, okay, and I often do this in a lecture. I put up a slide of an ITU environment with machines and doctors and patients, and I say, yeah, sure, what do you want to break? And I think it's just understanding that this is not technology as a space, it's healthcare. And in healthcare, we have to do things in an evidence-driven way. We have to really be careful about the harms that we might do as well as the benefits. So we'll move as fast as we can because the technology is moving super fast. And actually, we could stop developing new AI technologies today and spend the next 20 years just deploying what we already have, but it's not moving. It's exponentially increasing capability. But as slow as we need is really linked to that requirement for evidence, safety, security, really understanding what we are doing. And when we talk about ambient voice technology, what we're fundamentally doing is coming straight in to the decision-making element of where clinicians are talking to patients. It's their thought process, their time, how they spend it. And even that documentation angle, that's not inherently an undangerous task, shall we say. Therefore, it's really important that we evidence and super careful about how we implement it, which is why we call ourselves Tortoise.
Fantastic. I mean, I've never actually heard that explained in such detail, so it's nice to hear it. Yeah. So tell us more about this partnership and what we're doing together.
Yeah, and it's very exciting for us. I think it's great to find a partner that's sort of equally, well, super nice, which is very important, but also I think very much wedded to that philosophy in terms of we want to do things in the right way, we want to do things in a very careful way, and we're thinking about unblocking clinicians at that safest, simplest, most efficient end, which is obviously on the documentation layer. The partnership between ourselves in terms of communication we can talk about a bit towards the end, but is also extremely powerful. So here's Surgery Intellect, powered by Tortoise. And what we are trying to do with these partnerships is embed the Tortoise AVT system in an existing Surgery Intellect product, which you are all very familiar with. So this is how you'll see it pretty much coming down the line very soon. So it's a special Tortoise interface that we've developed wrapped around and in the Surgery Intellect product within Surgery Connect. So if you look down at a toolbar when you start a phone call, you'll see if you flip onto the Surgery Brain item, which is just on the toolbar and will appear in the future, you'll see this view here, which is the consultation in progress. And then when you finish that consultation, you'll see this specific UI, which pops up within the Surgery Intellect system of the consultation note, as you are familiar with some options there for paragraphs and comprehensiveness. And then if you flip to the next slide for us there, Hafsa. And then you'll get the codes. So here's some entities, blood pressure codes, option to generate letters. And then when you're done, you'll have the option to approve and save to Surgery Connect. Try not to say next slide, just like Chris Whitty. And then this is the view that you'll see. So from a medical device perspective, and we'll come on to that, you can do your edits and do your cognitive workflow within the Tortoise interface. And then when it passes, you'll have a place to store it within Surgery Connect for future posterity and anything else that you might want to do with it, but you won't be able to edit it. And that's quite important. And this is what that view looks like. So you've got access to the medical note here, the letter and the codes. You can find it in the call recordings. And actually, if you want to go back and process another call recording back through Tortoise, you can also instigate it from this screen. And you'll see there's a little brain icon, which is the Surgery Intellect icon next to some of these calls where that's already been done for you. And if you click the next one for us, and you can also obviously record the codes there as well. And then you can save that to the record, and we'll talk about progress there a bit later in the presentation. Very cool. So I think it's a really good segue into why Tortoise and what makes us a little bit different in the space. So we were the first medical device before it was cool back in 2023. And the reason for that really is there isn't, I would say, an existing framework other then the MHRA medical device frameworks, and Keith and Kirista can come onto that a bit later, that really does fit for AI technology. We were the first DTAC compliant scribe, but we decided to push past it simply because we thought the framework was appropriate, and we're continuing to work towards that and working towards Class 2. Some of the requirements of that system, including the live clinical evaluation systems, we've had to go away and really spend a lot of time actually doing some R&D and researching to be able to actually do proper post-market surveillance of this technology in production. And we can come on to some of the academic underpinnings of that in a second. We're the only British company in the space. I think that's pretty important, built for the NHS. And actually that means the system is designed for NHS workflows, SNOMED codes, ICD-10, but also the way that letters are structured, designed for our workflows. And we'll be looking at adding specific guidelines for the NHS in future iterations. Clinically evaluated, we've just finished actually Europe's largest trial of ambient voice technology, which is another key NHS England requirement for clinical evidence generation. Actually ended up at 17,000 patients, covering every sort of clinical setting, including primary care. Those results should be available to the public to read next month. And lastly, simplicity. So one of our first clinical papers actually was studying the cognitive load of using electronic healthcare record systems. So what we mean by that is when you look at a screen and it's very busy, is how you might interpret it. Your brain is literally trying to read and look at every button, and all these little micro processing is very distracting to you to try to achieve a macro task. EHRs are unfortunately a chief culprit of that philosophy. So we've very much gone the other way, simplicity by design. Number one, to reduce cognitive load when you use Tortoise, and number two, linked to our medical device status, every feature in Tortoise has to go through that medical device loop. Therefore, simplicity is key to safety. So that's why it's a very simple and hopefully very easy to use and intuitive product. Accreditations, again, super important part of what we do. Getting other people to check our homework is very much a commitment that we've made to maintain clinical safety and data security. So we're working towards Class 2A, and we'll be there probably hopefully by the end of the year. We've already done most of the ISO 13485 work that underpins that technology. For those of you who don't understand about this, we might come on to a bit more about the detail, but it does require changing basically the entire processes in your company. Evidence of every feature, validation and verification of why it works and why you've chosen to make those decisions, and a full audit trail throughout, plus post-market surveillance. So basically understanding when we deploy something in the world that it maintains all of the safety testing that we had when we had it in the lab, or rather in the office as it might be with AI. And we can talk about some of the difficulties with that, but also the benefits. We don't generate diagnoses by design. You can't interact with Tortoise via a chatbot, for example. That's a very hard feature to guardrail properly and is a big part of that clinical safety piece. Data protection, yeah, we don't store any patient data, and the sessions are auto-deleted after 24 hours. And again, from a cybersecurity perspective, storing vast amounts of transcripts, for us at least, seemed a very high-risk thing to do. And obviously, with great partners who are already data accredited, we can store data safely somewhere else without impacting the user experience at all. And lastly, secure by design. So most of our technology, architecture, features, all are designed to be compliant first. So cybersecurity, clinical safety, and data protection. Thanks so much. Cool. Okay, well, I'll come on a little bit to how we monitor quality, because I think that's a really important part. It underpins the medical device requirements, as well as our continuous improvement philosophy. So we've just published this in Nature, and I can share a link to the paper at the end of the webinar. But when we first started, there wasn't really a way to talk about accuracy for ambient voice technology. We actually had to define it before we could even start measuring it. So what we did is we first defined what a hallucination is in the context of the clinical environment, where you're having a conversation, passing it for various clinical facts, and then bringing that in to a medical note of what's relevant. And in that section, omissions of what's missing from that note that was in the transcript is actually very subjective. If you're a dietitian and you ask about a patient's crisp packet flavor of choice, that's really important. But if you're an orthopedic surgeon, you're just asking what they had for lunch to keep them talking, you don't want that in the medical note. So we had to develop some systems around both the quality and the quantity of the data that comes out through the note, which required a lot of human evaluators. So we built a platform called Creola, named after Creola Catherine Johnson, and shout out to the chat if anybody knows who that is, with 100+ human clinicians that hand labeled. And then we took that data and built AI systems that enabled us to monitor this automatically in production. So today, I can tell you any given note, any moment of the day that goes through the system, what the hallucination rate and the emission rate is. And we're constantly trying to improve that. And we're building a whole bunch of automatic guardrails to improve that outputs constantly. Obviously, always aiming to get to perfection. If we go to the next slide here. And as I said, we published that in Nature Digital Medicine. I won't dwell too much on it, but if you do want to have a read of that paper, we can share a link in the chat.
Hi, everyone. Thanks, Dom. So I know interoperability is a big question, and a lot of people have asked already, is Surgery Intellect integrated with my EHR? And so the answer there is, with great power comes great responsibility. And why is a Spider-Man quote relevant to this situation? Well, if you integrate, there comes its own unique set of challenges. Clinical risks might be increased, or coordination with third parties. And we really want to integrate safely and in a compliant way. So we're working on the IM1 integration. Every supplier is in that same situation of working with IM1. At the moment, we believe that no one is currently approved. So Surgery Intellect, Tortoise integrates with Surgery Intellect, and then we are working on the IM1, and that is also coming soon, and it is en route. Yeah, so that's that.
I'm just going to, before we move on, want to dip back to a couple of things. One, I think the film Hidden Figures will give you the answer to your Creola question. Okay, good. Yes. And the second question, far more important. I hope that data is entered into EMIS under the correct headings, which speaks to the point you've just made, Hafsa, about not yet being interoperable. I knew I wasn't able to say that.
Interoperability. It gets me every time.
To your EHR system. Yeah, exactly, that one. However, that is on the roadmap, hopefully, with any luck. And just to Dom, is that right? When it is interoperable, will it be filed under the correct headings?
Yeah, it's a super good question. I think we're looking at how best to do that now with the IM1 API, as well as potentially working with the partners on that side directly. Obviously, we know who they are, but they're not here to represent themselves. So we'll see how we get on. The output of Tortoise is already in the correct headings and doing structured data. How it's stored in the data model, we'll just develop that as we go. So kind of watch this space, but we'll definitely be representing it, at least in the database, in the correct format for sure, which is problem-based charting.
And I think we need to unpack it just a little bit more, because there are a couple of questions coming. So Jane thought there was an option for it to be saved to the record. To that point, it is on the roadmap, but as things stand today, there is no AVT system that integrates directly with an EHR system, correct?
At least not in an approved way. So, I mean, obviously we can send data into the record as it is for now. I think, so for those of people who don't know what we're talking about, IM1 is the way that you write data into EMIS and TPP. It's essentially a route for data. It's called an API. It depends on how techy you are. The reason that's important is it's not actually managed by any of the companies. It's managed by the NHS itself. Now, the NHS is obviously very worried about AI content being saved to record. And the reason for that is because if you think about what we're doing, we're creating AI text, having the clinician review it. But once it's saved to record, it's actually impossible to work out where the provenance of that data came from, at least as today's things stand. Therefore, the assurances and the accuracy of those systems has to be at the highest bar before they're allowed legally, I suppose, to use the IM1 system. So the IM1 NHS England have set up an assurance process. We're going through that process now. I don't think it should take that long, because Tortoise, for one anyway, did most of these assurances last year. However, they just want to double check everyone's accuracy requirements, so that data that goes in is going to actually be the truth. And obviously at scale and over time, that could become a massive problem if they don't do it right. So that's why there's a bit of a delay doing that. somebody's mentioned somebody else, and I won't go into competitors, but yes, the actual truth is no vendor is using IM1 correctly at the moment. We're doing it properly. As Hafsa said, with great power comes great responsibility. We can send a whole bunch of data in, but it's just not the process as has been set up by the people that actually own that pathway, and they're guarding it for a very, very good reason. So we're being very respectful of that.
As fast as we can, as slow as we need, I think is the point. We're doing things right. And to that point, we're getting other people to check on our homework. I love that line, Dom, so I've written it down, which is a great introduction, I think, to Keith and the team. So I think we've just got you at the moment, haven't we, Keith? So it's a change to our norm.
Yusuf's on the call as well.
Oh, good. Well, I just can't see him yet, but hopefully he's there and he can join us. So in our change to our normal format, we also have Dr. Keith Grimes on the call and Dr. Yusuf Oscrochi from Choristica, both with us today. Tremendous to have such passion and expertise on the call all round, I think. Keith, would you mind, for those that don't know, just giving us a little bit of a background about Choristica and what it is that you do?
Yeah, thank you very much. And hello, everyone. Yeah, my name's Keith Grimes. I have to say now that I'm a former GP, but I was a GP for 24 years from 2000 to 2024. And I'm a very geeky GP, so I've always been working in tech. And I was based here in the southeast in Eastbourne. So the essence of what we do at Choristica is a health tech innovation consultancy, and we help people either building, buying, or deploying health tech, including AI, do it fast, because people want to move fast, but safe is very important, and doing it smart. And we do that principally by working with either people building or buying and deploying it to do things like clinical safety and data protection and all the associated compliances as well. And we've been doing that for a little while now. It's for me, it's very, very simple. If you're going to use any technology with a patient, is it safe? Is it effective? Is it secure? That's a nice simple thing, and there's a lot of different, sometimes quite complex sounding compliances in place, and our aim is to try and help everyone involved in this make sure that they do it right, because doing it right doesn't need to be that hard, and you also need to do it not just once but continue doing it. So you've heard Dom talking about post-market. This is keeping an eye on things afterwards. If you think about human clinicians, and if you think about drugs, they go through stages before they go and meet the patients, training and the drug trials. And then afterwards, we've got all the work that we do for clinical governance, but also drug surveillance too. And technology can be incredibly powerful, should really be subject to the same things. So as we do this, obviously know of the great work that both Exxon and Tortoise have been doing in the past, and came in at their invitation to sort of look at what they're doing. Part of this is assuring both parties that the work that they've done is compliant and ready for deployment, and also keeping an eye on things as the products develop as well, or the world changes, to make sure it stays that way. But critically, and that is the important bit for everyone on the call here, is that it's not just about knowing that it's been done right, but also when you start using this, you have a part to play in keeping it that way. And I'll speak a bit about what that means for clinical safety. We've got Yusuf talking about the data protection, but you're going to want to make sure that you're satisfied that it's all right and that you're keeping an eye on things. So that's principally what we're doing in this partnership. And if I boil it down even simpler, if we just first talk about clinical safety. Clinical safety is a standard that's been in place since 2012 in England. It's not legally enforced in places like Scotland, Wales, and Northern Ireland, although it's considered best practice. And at its simplest, this is just describing what the technology does, who it does it to, and where it's being used, and showing that you've thought carefully about how it might go wrong and spent some time controlling how it might go wrong, proving that you've done this work, and then presenting it as a document saying, this is why I think it's safe to use. And if you use it this way, it will stay that way. And that, at the heart of it, is clinical safety. So it seems pretty straightforward to me, but I do spend all my life in it. And the manufacturers do part of it. And then when you deploy it, so in a general practice, there are things that you want to do to make sure that everyone knows how to use it with training. You might want to do some quick tests beforehand to make sure that it's working well in your setting and that it performs the way that you want to. And then once it's up and running, you might want to monitor it. And of course, even with great technologies, things can sometimes go awry. So you want to make sure that if any incidents arise, that you recognize them and capture them if there's any complaints come in, and that needs to be fed back to the manufacturers. Now, I think that's the bit that's causing some people some worry, because goodness knows you're all busy enough as it is, and the idea of doing extra work on top of that is maybe a bit off-putting. You know, who's going to pay for it? Who's got the time? Do we have the expertise? This is the critical work that we're working on. Having spent a long time in general practice, I understand a lot about how practices work, particularly in terms of the governance structure. So our work is about making sure that all these compliances can be woven in to your day-to-day work. So it becomes essentially a line item within the governance and quality assurance work that you do, meaning that this is something that is directly applicable, that you're using it safely and can demonstrate this to yourselves, but also the CQC and everyone afterwards, and get the very most out of these products now and in the future. So we're doing a few things in there, helping assure the work they're doing, working with them, sharing best practice and knowledge, but critically making it applicable to you who are using it as well. So that was the clinical safety side. Yusuf should be on the call as well, and I'll maybe help him talk a little bit about the data protection side. So knock, knock, Yusuf, are you there?
Hello, everyone. Good morning. I hope everyone can hear me.
Yeah, I can hear you fine.
Lovely, fantastic. My name is Yusuf. My name is Public Health Consultant, and I'm Head of Safety at Curistica. So yeah, Keith and I work very closely in making sure that clinical safety and data protection are aligned, because we find that together they form more than the sum of their parts. And one of the things we do is try to synergize what the mitigations and risks that we identify in the clinical safety case in the data protection impact assessment, and vice versa. So one of the things we try to make sure is that you're always complying with UK GDPR, not just because you have to be, but because it's better for yourselves and better for patients. You've all seen the latest press releases, I'm sure, both from NHSE, but also in the wider press, and people are going to start asking questions, especially around the use of AI in their clinical care. It's important to know as well that the ICO is very active on this. There is actually a whole chapter that they've dedicated to the use of AI in products used in just all products, but specifically products in healthcare. And now DPIAs need to have these additional elements within them to meet sort of the ICO requirements. So Keith and I have been working closely with the teams to try and update everything we have to cover that. So that includes things like clearly laying out how the AI works, what the risks are within it, such as misclassification or the risk of singling out, etc., and also what kind of harms can arise from it. So that's all on the ICO website, but we've incorporated our DPIAs. But yeah, happy to chat about any questions anyone has on data protection, clinical safety, medical devices, or otherwise. I'll hand back to you, Lucy.
Thank you. Thank you. Well, I do actually have a question, believe it or not. One specifically for you, Yusuf, I think. What are the key data protection elements that people need to be aware of with the use of AI?
Yeah, that's a very good question. So the most important ones that we think, and obviously Don can come in on here as well, and I have said if you want to, is that as you are the GP practices are the data controllers. So ultimately, you are responsible for ensuring that everything that you sign up to is valid, robust, and actually legally compliant. And one of the things I would say is I've seen many examples of DPIAs, template DPIAs I've given to practices that when you look through them, don't pass muster, essentially. So be very careful when you get template documents through. Be very careful, go through them in detail, look at them, make sure that you're aware of what data you're allowing the processors to use, where it's being processed, geographically, what the safeguards, organization, and technical they are. Because ultimately, what you're doing is you have permission based on your function to process special category data, which means that's health data. And by signing a DPIA with that someone else provided, you're essentially using your legal basis to use and process that data, and you're delegating it to someone else so they can do the same. So you need to make very sure that they're using the data in the right way for the right purpose, the right safeguards are in place, so people's individual rights under GDPR are still upheld, and most importantly, make sure that they are deleting that data when they don't need it anymore. There are very few reasons that processors need to store, especially special category data. So I know Dom's team, all the audio recordings are deleted. They don't hold it. They don't need to hold it, so they don't hold it at all. So make sure that actually any health tech appliance you get follows sort of the same good standards.
Okay, is it worth mentioning that I've just had a little note this morning that says that Exxon now have an overarching DPIA for Surgery Intellect, and if anyone is interested in the starting the approval process, please put your ODS code in the chat, and we will reach out to you directly. I presume you've been involved in putting that together, Youssef?
Yeah,
he says no, and everything falls apart.
No, I mean, Exxon has a very competent DPO in Richard Newell, who I think is on the call as well. So Richard, myself, Nikita and Hafsa have been in discussion trying to get this done. It'd be a really important point. This overarching DPIA is meant to be an executive sort of approach. So it says, this is how all these things integrate together. Each component still has its own individual DPIA, but this is sort of the tying up document that says this is how they all interact together. So just to be clear on that, it's sort of if you want to get the executive summary, you'd look at this. If you want the details, you'd look at each individually.
I might just comment on this as well. As we talk through this, I'm sure there's some people listening to this thinking it sounds rather complex as well. Part of what we're going to be doing is people that you see on the call, Dom, Hafsa, myself, Youssef, you'll see our faces again in the Exxon Academy. The materials helping explain this will be available to you as well, because it can get quite complex, but it can also be explained in a simple way. You have to be able to understand this too, and that doesn't necessarily mean that you all have to be CSOs, you all have to be data protection officers, but it is important that it's made clear to you. So we'll be providing some of those, and we're always happy to hear if you've got any unanswered questions, or if we haven't done this right as well, with your position as data controllers and also providing care to your patients. You're going to want to understand this and potentially even explain it to your patients in some form as well, because some may have questions.
I think that's a really good point. Yeah, absolutely. Another question, I suppose, Keith, that I've seen bandied around a fair bit is we've seen some people suggest that the use of AI in any healthcare, the use of any AI in a healthcare setting needs to be a medical device. Do you want to speak to that point as well?
Yeah, sure. So the issue about medical device status is interesting, and I think it is easy to sort of think, well, maybe the best thing to do here would be to make absolutely everything that's used in healthcare a medical device. But medical device regulation is rather specific for certain things. In essence, what you're doing is a medical device qualification, depending on which country you are, is essentially looking at whether the thing that you're looking at, in this case we're looking at software, is the intended purpose, what's it intended to use. And if it's intended for use in any particular areas like diagnosis, prevention, monitoring, prediction, prognosis, treatment, or alleviation of disease, he says, looking at his notes here as well, and it achieves it through software, then this may well be a medical device. The second thing to say is that the more powerful, with all this great power, comes great responsibility, in this case risk, and so there are different levels of classification. Class 1, as it currently stands, is the lowest risk classification, and that could be self-certified. Class 2A and beyond, up to the top one of Class 3, requires external validation through things called approved bodies. All of that being said, health technology is used across health services and care settings as well. And it may not be used for those direct purposes as well. So there may be an administrative function or an educational function, or just simply processing appointment times and everything. Now, these aren't directly being used for those medical purposes, but they will still potentially impact on the patients and their safety and risk and everything, which is why I very much like working in clinical safety, because to a greater or lesser extent, whatever technology you're using in delivering patient care still has to have this consideration. And of course, if you're using a digital technology and data is moving around, then data protection is going to be involved, and cybersecurity and so on as well. So AI means a lot of things, and AI can do a lot of things as well. So regardless of what the technology is, you have to think about what is it intended to do? How is it being used? That is the thing that will determine about whether it's a medical device or not. So at its simplest, let's say, you might use AI in whatever form it is to actually assist with some of the administrative and non-clinical functions. It may not, therefore, be a medical device, but you still would rightly expect the manufacturers to consider the risks that might come from it being used and try and control those risks and make sure the data is safe as well. So hopefully that helps answer your question there. And everyone, I know it maybe feel right that, well, literally everything that goes out there would come under some kind of like approval body. There's a lot of technology out there as well. And so I think that would be incredibly difficult to achieve, but also potentially overdoing it. However, there are standards in place and laws that allow us to be confident about using the rest. The thing that I would like to see, and I spend a lot of time talking about, is that at medical school and postgraduate training or any of the clinical sort of specialisms, there's very, very little taught on this. And as a result, people are left wondering a little. You might get something on the clinical governance and the drug development, but nothing on technology. I'm working hard to try and change that, but also where we are now, trying to get people to understand what their role and responsibility is to use this, because we do want to use this technology to help us. We've got a lot to do.
Quite. To that point, I'm conscious I'm stealing all of the question time here, so please feel free to pop your questions in the chat. Now is the time. If you've got burning ones, just pop them in there and we'll get to them. And whilst people are thinking about that, probably to Dom and to Hafsa, I mean, this is a lot, isn't it? I'm quite overwhelmed with the information here, and I imagine that some of our viewers are too. Is it all worth it?
Oh, well, that's such a good question. Is it all worth it? Do you mean just like life, or specifically this?
I've only got 10 minutes left, Dom. This is yeah, you're absolutely spot on.
10 minutes. I'll tell you what life's about. No, I mean, what are we actually trying to do, right? And what we're trying to say is, if you look at what the average doctor does anywhere in the world, funnily enough, this is now a universal problem. About 60% of their time is spent doing administrative work on computers. 60%, right? The majority of your time is not seeing patients now. It is doing the administrative work that's associated with that. And the big advent of that is because we've digitized everything. We have to type, we have to do forms. Now, there's lots of benefits from that to the system, but to the patient-clinician interaction, it's massively deleterious. My favorite word, never had to say it out loud. So what we're trying to do now is basically shrink that admin time. You know, if we go from 60% to say 15% of computer time, you've just doubled the amount of time that you have to spend with your patients in terms of quality of life, in terms of productivity, in terms of energy, in terms of just making better decisions. That is what's the goal is, right? It's to make it worth it. So at Tortoise, like, it's all about building the better interface. So ambient voice technology solves the documentation problem. We'll be working on the two adjacents to that, which is finding information in the system and then doing some of the downstream work as well. And that gets you to that sort of 60% compression to 15, which means we've suddenly got basically twice as many clinicians in the NHS and other healthcare systems. And obviously everybody on the call can imagine how much better healthcare would be to do that. No one on this call ever got into healthcare because they didn't want to work hard. It's just we want to do the meaningful work, not the administrative burden. I don't know if Keith can speak to a bit of that as well, because he's obviously come out.
Yeah, absolutely. And of course, whilst I'm not practicing right now, I was very, very, very full-time for a long, long time and spent a lot of time using technologies, not AVT because it was a wee while ago, but I have used that in between times. I think everything that Dom said is absolutely correct. But when I speak to people about using AVT, they often lead with something different, which is they just feel better. Now, they'll put it in a different way. They'll just say they're paying more attention to the patient, or it feels like how they used to practice. You know, sure, they're saving time and there's other bits and pieces too. But for me, this is one of the really special things about AVT particularly, is that it returns something that I don't think any of us thought we could have, which is basically a little bit more actual direct contact with our patients as well. And of course, that is the core of clinical practice. That is where the really important things happen. Sure, we're doing all the other transactional stuff, and we've been talking in the chat here about coding and so on. But that is the bit that most people speak to me about. And, you know, Dom, I'm sure you kind of seen that too. I know in some of your studies you talk about how even the patients feel about this. When I used it, patients were stunned that what they said actually made it into the notes, and so on. So there's happiness all around from that regard. Of course, that in and of itself, sadly, is not enough to make a difference because we've got a lot of work to do as well. But I think just making the act of being a doctor with a patient better is prize enough. Still comes with risks that we have to mitigate and everything like that. But time saving, getting the codes right, better quality notes, summarize it, the whole lot comes with it too. But I always want to emphasize for this particular technology, and I've seen a lot of technologies, this is one of those unusual moments that I think is worth paying attention to.
Okay. Thank you both. That was an in-depth answer to my flippant question. Yousef, you've spotted a question in the chat you're really keen to get to. I think it's Rachel's.
Yeah, so Rachel's asked me a question about network of CSOs rather than silos. Absolutely agree. I think, you know, we don't want to duplicate work, especially hazard log work, because most of it will be the same between different deployments. However, there is enough variation in individual deployments that each one would have to have its own sort of individual look at it. The ways we've seen this addressed previously are that essentially one person does it, and then everyone agrees to use it exactly the same as that one person does it. Whether or not that's feasible or not is an entirely different question. However, just to be clear, that the 0160 requirement is for you individually. And if you take on what someone else has done, and there's no additional work on it with respect to actually customizing it to your use case situation, that's not a proper implementation of it. So while it can be done, it needs to be done with additional safeguards around it. But again, it's entirely possible. It just needs that sort of bit of overarching tweaking to make it robust and compliant, so to speak.
And maybe I can pick up on that as well, because there was a question from Morgan Daly a bit earlier on in the chat about what's the approach to support during rollout. And then you've mentioned patient consent and info materials, support with developing an AI policy, support to create hazard logs, etc. So yeah, you'll be pleased to hear that this will be coming from the kind of three parties in here as well. Dom and Exxon can potentially speak to their side about things like patient materials and so on, but I can speak specifically about how we're approaching. So Curistica, the thick end of the work that we're doing right now is taking all these tasks, like Yousef said, you know, you can get to a point where it's very common between practices, but what's that final mile, what's that final distance as well, and what's needed for that? So my hope, and hopefully we'll prove this to you, is that we can make identifying when you're different and making the necessary changes as lightweight as possible that could be deployed or done by a CSO in your own practice. Some of you may be CSOs who want to train up in that. Or it could conceivably be done by a CSO across several practices, a small cluster of PCM. And we're still working out what the best way to do this would be too. And then there'll be a core element that comes with you coming on board. And then for those that need specific CSO, DPO support, then that's something that Curistica will be able to provide for you as well. And we're still working on the details of that. We appreciate that there's a lot of demands on your time and resources too. So this is about right sizing it. There'll be bits that you can do yourself, and we'll work very hard to make that as easy as possible. But for those areas where there is increased complexity, we'll be with you to assist you there. And also, Dom, I just wanted to say, and Dom and Hafsa and Exxon too, is like, these products aren't standing still. You know, technology moves fast, and they're constantly and sensibly and responsibly improving them. As those changes come, the support will reflect that.
That's a great point to end on, Keith. So I'm almost loath to ask this, but any final comments from Dom, Hafsa?
No, just thanks so much. I think we see a tremendous amount of potential, as Keith said, into the future of what we can do together, specifically around communications. And it's exciting how we can get going.
And I'm just scrolling through the chat and I'm seeing lots of people registered interest. So really excited to get working with you all.
And just from my perspective as well, is as we go into this, hearing from you about what works, what doesn't work, and in particular your anxieties. It's nice to work with this team because it's all about openness as well. It's not just AVTs. There are lots of technologies. I know you have lots of technologies in your practices, and to a greater or lesser extent, some of this will apply there too. So let us know. We can adapt these things and help support you. So safe, effective solutions come and solve the problems that you're facing and the problems that your patients are facing too.
And there has been a question about whether we'll be doing a demo around Surgery Intellect. I think it speaks volumes actually that we've led with this session first around the governance and the guardrails ahead of showing the product in its entirety. Naturally, we will be doing a product demo in due course, but this was the important one that we wanted to get under our belts beforehand. So I hope you've all enjoyed the session. That is it from us today. With a minute left, I'm going to wheel through my closing statements. A really big thank you to all of our guests today. You've been absolutely fantastic, and to the audience for all of your participation. We couldn't do it without you. Our next webinar is planned for the 23rd of July. Look out for the link, but with everything moving so quickly, the subject matter is likely to be decided nearer the time. It could be a problem. If you would like any further information on anything we have spoken about or any pressing questions that we haven't got to today, pop your ODS code in the chat and a member of the team will reach out. We will make the recording available in the next few days via email to all registered attendees with all the relevant links. We hope to see you back again next month for more, of course. In the meantime, on behalf of everyone at Exon Health, at Tortoise AI and at Curistica, have a happy and healthy June. We'll see you in July for more. Take care and thank you.
Thanks so much.
Thanks. Bye.
Bye-bye, everyone.